So we've had a few more folks join us this evening. I'm going to keep admitting them as they join, but I'd like for all of us to go ahead and get started this evening. So for those of you who don't know me yet, my name is Katie Barber. I'm the membership manager here at the Health Museum. And this is the third week in our new series of member engagement programs where we bring all of our members together with a few featured guest speakers and bring our exhibits to you while the museum is closed. So tonight I'm really excited to focus on our exhibit Outbreak, Epidemics in a Connected World. We're going to be specifically focusing on the close to home portion of the exhibit. If you haven't had a chance to walk through the exhibit, I highly encourage you do so once we're able to reopen. But until then, you are able to view some of the exhibit thanks to the Smithsonian. They've recently allowed us to share their virtual exhibit online, so you can scroll through and get a pretty well understanding of what we're presenting here at the Health Museum. And so with me tonight, I have Becky Seabrook. You might also recognize her. She's our Senior Director of Guest Experience. And our two special guests, I have Dr. Heather Wooten. She is a medical historian at UTMB. And I also have Dr. Scott Weaver. He did a few short interview clips Q&A session and has been a little active on our YouTube channel, so you might recognize his face. But we're very excited to have all three of you tonight for the discussion. Just a couple of housekeeping things for everyone that's joining us. If you have a question that you'd like to ask Dr. Weaver, Dr. Wooten, or Becky, feel free to drop it in the chat box. That way I'll be monitoring them and can feed them as we continue on for the evening. So without further ado, Becky, would you like to kind of introduce us to the close to home section of Outbreak and tell us a little bit of background of why you decided to bring this new aspect to the Smithsonian's exhibit?
Sure. So the exhibit is called Outbreak, Epidemics in a Connected World, and it comes to us from the Smithsonian. It was developed by the National Museum of Natural History, which is one of the Smithsonian museums. And they created the exhibit that they have at that museum to come out in 2018 on the 100th anniversary of the flu pandemic of 1918 that we've been hearing a lot about. And it was meant to run in that place for 3 years, so through next year. And they decided not to travel it as an exhibit, but to make some of that content available to other organizations and other museums. And I was really, really excited to see it. I find a lot of the information fascinating, which is why I find Dr. Weaver and Dr. Wooten's job so fascinating. At the time when we decided to bring it on, that would have been last summer, we had no idea we would all be in the middle of a pandemic right now. But these outbreaks are a lot more common than people think. Now, I think the Smithsonian does a fantastic job in the exhibit of really speaking to the public health side of the exhibit. So they talk a lot about this, the concept of One Health. So the interconnectedness of human health, animal health, and the environment. And also the importance of a coordinated approach to dealing with outbreaks. So not only the location, so the local and the national and the international coordination, but all different fields. So bringing in veterinarians with clinicians and researchers, public health officials, government officials, grassroots organizations to really have an effective defense against these outbreaks. And I felt like the exhibit did a fantastic job at talking about that and making that very accessible to people that might not know anything about outbreaks. The one thing that I really wanted to do with the exhibit was bring in a human element of it, which we're all experiencing right now. And we did that by creating a section called Close to Home. And in Close to Home, we talked about 3 different outbreaks that impacted the greater Houston area. So we talked about the bubonic plague outbreak that happened in Galveston and some other port cities in the early 1900s. So that was 1920 when it impacted our area. We talked about the polio epidemic, which was especially hard hitting in the 40s and the 50s. And I'm sure Dr. Wooten is going to be able to talk a lot about that. But what was one of the things that was really interesting about that one is that was really the genesis of the museum. Some of the money that was raised from funds during the polio vaccine campaigns was the seed money for the founding of the Health Museum and some of these public education exhibits about health and medicine. And then the third one that we looked at was HIV/AIDS, which really came into people's awareness in the early 80s, so 1981, 1982. And really comparing and contrasting those and telling the story and looking at the pathogens that cause them and where they're similar, where they're different, and how people approach these outbreaks. So that's kind of where the close to home piece came from. And it was incredibly helpful to have people like Dr. Wooten, who essentially wrote the book literally on polio in Texas, and to have these incredible resources as we were developing the ideas and the content for the exhibit.
Awesome. So really, even though everything we're experiencing, we may not have experienced before, but this has happened in our history and not so long ago.
Yeah. Absolutely. Dr. Wooten, I don't know if you want to chime in. It must be fascinating being a medical historian and oftentimes writing about these things like polio, and now you find yourself in the middle of a very historic outbreak. I'm kind of curious as your take on it. And maybe you could also talk about some of the other outbreaks that have happened in the area.
Yes, well, it absolutely is. And I would certainly say you see the parallels, of course. You also see the differences. I would say certainly with all epidemics, whether it was polio, whether it was influenza, whether it was yellow fever, all of those were epidemics that hit this area. You definitely have the fear. You definitely have the suspicion. You definitely have public health officials playing, or business officials, playing things down at first, and then before you have to admit this is truly an epidemic. You have closings to an extent. It just depends on when the epidemic was, but there was never a complete shutdown of any of these other past epidemics like there is with this one. However, there always, with each one of them, especially with influenza and polio, it had to do with closing those gathering places. They were certainly making those connections. So those are definitely the parallels you see across the board. And also how the disease seems to come suddenly from nowhere. It's unexpected, and then the public search and the public health search for a cure and a vaccine is in with each one of them as well.
Yeah, it seems unexpected, and yet it shouldn't be. I guess, Dr. Weaver, we should probably be prepared for these. We know that they happen fairly regularly, even if all of them don't rise to the level of awareness because they may not be impacting us directly. But how common are outbreaks, Dr. Weaver?
Well, they happen all the time, and they're happening more frequently recently. If you just think about the last 10 years, starting around 2014, we had two major outbreaks. We had Ebola virus in West Africa, completely unprecedented, an order of magnitude plus more human cases than ever been detected before. The first time the virus was transmitted in major cities in Africa, and really the first time we saw very many cases exported around the world, including here to the United States, even here in Texas, where we had one case of a West African man and two infected healthcare workers in Dallas. So all those were unprecedented. The same year, we had a major outbreak of Chikungunya virus that swept through the Americas, caused millions of cases in Latin America, dozens of cases here in the southern United States, a very debilitating, fortunately not very often a fatal disease. But then right on the heels of chikungunya, we had Zika virus, which peaked in our region in 2016. We had several hundred cases here in the United States. Again, millions of cases, first time ever in the New World, as far as we know. And then only 2-3 years later, we have this coronavirus emerging. So it's really been one after another. And it's been kind of head spinning for those of us who work on these emerging diseases to go from one to the other. And unfortunately, to see the kind of short memory span that sometimes our country has towards addressing these emerging diseases, where we've literally taken money from the one that just occurred to try to fund the emergency response to the newest one coming along. And I hope that this new SARS coronavirus is going to get us out of that pattern, to recognize that we really need sustained efforts to address these emerging diseases. We can't just wait till the next one comes along and respond retroactively.
It seems like a lot of what's going on is framed as the ability to get the economy going versus what science is telling us to do. But it seems to me that if we prepare and we invest in a lot of these measures that you're talking about, it doesn't have to be sort of one against the other, but they could be working together to more effectively deal with some of these future outbreaks.
And I think that even going back to some of the earlier ones that Dr. Wooten mentioned, most of these could have been anticipated. Certainly this coronavirus outbreak was easily anticipated in 2003, when I think we narrowly averted a pandemic of an even more deadly version of a coronavirus, the first SARS coronavirus. Thinking back to yellow fever, the last outbreaks we had on the Gulf Coast here in the 19th century were not the first. There were others in the Americas dating back 1 or 2 centuries before that, and we're still having yellow fever outbreaks. We had 2 of them starting around 2016 to 18. Fortunately, they didn't reach the United States, but they very well could in the future. And probably the only one that you were just discussing was that maybe was a little more difficult to anticipate was the polio virus, because the situation with polio changed very dramatically when we improved our water supply, when we had safe drinking water, and people started getting infected a little bit later in life when the disease tends to be more severe. So that was not as easy to predict in the future. Most of these, there's no secret what the risks are, and we really just have to develop the political will to be more proactive, and especially to fund our public health programs. They've been badly neglected over the decades.
Yeah. You mentioned the polio virus, and Dr. Wooten, one thing that's been really fascinating in the exhibit is when we go in the exhibit and you talk with some of the guests that remember the polio outbreaks. Oftentimes, I've heard people talk about the iron lung and how they associated it with the relative, or they remember when they were no longer able to get together for family gatherings. And it was really interesting to me, some of the parallels. Are you seeing some of that, or what do you see as the similarities and differences between what we're seeing now and what we saw with polio?
Well, I think the thing with polio that made it so interesting, as you say, is it resonated with everyone, because everyone knew somebody or it either happened to them. And I think the thing with polio, which I think we are going to see with coronavirus, is there was, for a percentage of individuals who contracted polio, it was a smaller percentage than the overall number who had it, which was just about everyone had a mild case of some kind. They just didn't know they had it. But for about 10% of individuals who had paralytic polio, and then a smaller percentage that came down with bulbar polio. And of course, 10% of those individuals, a lot of them were able to recover. But in later years, the virus came back, the symptoms came back in terms of post-polio syndrome. So I'm thinking of it in terms of the coronavirus. We are seeing individuals who are physically or suffering severe damage and are going home, and then having to go back to the hospital because it had affected them in such a way that they now came down with stroke or things like that. So I'm seeing that it manifests permanently. Both diseases have the propensity to do that. And we're still seeing what coronavirus will eventually, how this is all going to play out. That's the whole thing with historians. They wait and see. They wait and see the data. So I can't say a whole lot of, predict a lot as to how it's going to go, as opposed to polio. But you are seeing that parallel.
Yeah, that's interesting you say that, because I remember that really stuck out to me as we were researching polio, was just how many people had it and either had a very mild case or didn't know they had it. But then the people that were severely affected were very severely affected. And that was really where a lot of that fear came from, because it wasn't really clear why one person would be affected more than another. Yeah. Dr. Weaver, are we learning anything more about what makes one person more likely to have a severe reaction to if they develop COVID-19? I know it's kind of a moving target. We're learning a lot as we go, but is there anything that's become more clear in the past couple of weeks?
Well, we're certainly learning a lot more about what things predispose people to more severe disease. The list is growing all the time. It's not changing dramatically. We knew a couple months ago that people in older age groups were at high risk, that people with chronic lung disease, chronic cardiac disease were at high risk, diabetes, smokers. I don't think we've learned a whole lot in the last 2 months. I think the next step needs to be understanding why disease severity varies so much. Why do these groups of people, or why are they predisposed to more severe disease? And really the bottleneck to reaching that point is animal models. So we're just starting to test different animals in the past month to see what responds like people do. It's looking like most of the non-human primates, which are usually our gold standard models, don't develop severe disease at all, even when they're tested as older individuals. Hamsters and ferrets develop a lot of the shedding of the virus that people do, but they also don't typically develop very severe disease. And there are a number of transgenic mouse strains that have literally been brought out of the liquid nitrogen tank, where they've been sitting for many years since the interest declined in coronaviruses a few years after 2003. And those are now being bred in commercial colonies. And we're hoping around June and July there will be enough animals to begin doing large-scale trials to look at what the disease process is in those animals and to see if it is similar to what happens in humans. And then we can really start to get at the fundamental mechanisms. But unfortunately for now, the only thing that's available is some of the more expensive and difficult to work with animal models. Not very many labs around the world can work with those. So progress is a little bit slow during this phase in understanding the disease.
Now, as you mentioned, this is not the only coronavirus. There's a number of coronaviruses that have infected humans, and probably many more that infect animals that have not crossed over to humans. How does this compare to some of the other ones that we know about?
So there are basically 3 kinds of coronaviruses that we knew about before last December. Mm-hmm. The first are coronaviruses that have probably been infecting people for hundreds of thousands of years, maybe longer. Those are coronaviruses that cause disease that we usually refer to as a common cold. Fairly benign disease. We get it's seasonal, just like influenza. We get a cold, we have a cough, runny nose, sore throat for maybe a week or 2 during winter. In this country, we rarely diagnose any of those infections unless they're influenza. So if you go to your healthcare provider, they will probably offer you a very rapid influenza test. And if you have influenza, we have antiviral drugs that can be used to treat you. If you come in early during the course of the disease, those drugs can be effective against most strains, and that can shorten the disease course in those people, and it can reduce the risk of severe disease in high-risk groups. And we have to remember that influenza has many similarities to COVID, and one of them is that older individuals, but also very young age groups, do have severe disease and often die. So a typical year in the United States, we have 30 or 40,000 fatal influenza cases. So we're a little above that with this coronavirus, but not way out of bounds of our normal flu mortality. The difference is it's happening much more quickly in a shorter time window this year. But if you don't have influenza, and you don't have any signs of a bacterial infection, like you could be tested for strep throat or something like that, then we rarely diagnose you. We assume you have one of a group of many different viruses like rhinoviruses and coronaviruses that cause a very similar, fairly mild disease syndrome. It's rarely life-threatening, so you go home and wait it out. You stay home until your symptoms improve, and then hopefully you don't go back to work before you're at least stopped shedding those viruses. But so we've known about those. There are 4 of those coronaviruses for a long time, but never paid very much attention to them. Then came SARS in late 2002 with the outbreak in early 2003. And that virus was fairly quickly discovered to have come from bats through animals called civets that are sold in live markets in China. So there was more or less a smoking gun how those viruses got into the human population. They spread quickly in parts of China and Hong Kong, and they were transported in infected people to various parts around the world. But fortunately, the outbreak was shut down quickly after only about 1,700 cases. And even though that virus produced much higher mortality rates than the new coronavirus, the outbreak was shut down probably just in time to prevent a pandemic, which could have been much worse than what we're seeing now. And then the third coronavirus, SARS, stands for severe acute respiratory syndrome. There's another one that produces a similar disease in humans called MERS, Middle East Respiratory Syndrome, that stands for. And that comes from camels, probably also ultimately from bats, but through camels. And most of those cases, fortunately, have been people who directly contact camels. They own camels or care for them in the Middle East, with a few cases of hospital-borne transmission, especially in South Korea. But fortunately, that virus doesn't spread very efficiently from person to person, so it's never really been a threat of a pandemic. But it causes a very similar disease, with even higher mortality than the 2003 SARS virus. So we really only know about these 7 coronaviruses now that are pathogenic, cause disease in people. And we know very little about really any of them at this point because they've only emerged recently or we've ignored them for a long time.
Mm-hmm. Interesting. Do we know if there's any immunity conferred from having had some of the other coronaviruses, for example, some of the milder ones that cause the common cold? How likely is it that that might help against a more severe reaction to the SARS-CoV-2 virus?
So we do know quite a bit about the relationships among these viruses, which ones are most similar to others, because we can determine those things now by just determining the sequence of the genetic material. Mm-hmm. So the closest relative to the new SARS coronavirus is the old SARS coronavirus. Mm-hmm. And we do know a little bit about immunity to that virus because some people were followed who were infected in 2003. Mm-hmm. And most of those people had relatively strong immunity for about a couple of years after infection, and then it started to wane. Mm-hmm. And then for the common cold type coronaviruses, we know that immunity is short-lived and people can be reinfected with those viruses. So we don't know for sure. There are significant differences between the new and the old SARS coronavirus, but our best educated guess right now is that this new virus will generate immunity in most people that will probably protect them at least for many months or a few years from reinfection. But that's by far from certainty because we're learning a lot every day about this new virus.
Yeah. Now, Dr. Wooten, Dr. Weaver was just talking about some of the similarities that we see between the flu and COVID-19. And a lot of people have been talking about the flu pandemic of 1918. I remember, I don't know that a lot of people really even knew about it. Now, all of a sudden, a lot of people are talking about it. What lessons were we able to learn from that pandemic? Why has that become such a topic of conversation now that we've got this outbreak with COVID-19?
Well, I think the reason people are so interested in it has to do with, you know, the symptom similarity. Where, you know, you're definitely dealing with you know, acute respiratory distress, and the fact that, you know, just the epidemic itself and how the public reacted to it is very similar. It was highly contagious. It affected a massive amount of individuals. So, you know, we've had with COVID-19, in the United States now, we've lost 50,000 individuals. With influenza of 1918, and really it was through 1920. So it went in waves, the way we were expecting COVID will probably do the very same thing. But the fatality rate for influenza during that epidemic was 675,000 just in America, United States alone, which is more than the Civil War. We always think of the Civil War as being the ultimate bloodbath in the United States, but here that virus in an incredibly short period of time was able to take that high fatality rate. So, and then of course it was 50 million dead throughout the world that we know, and 500 million infected. So I think we were looking at it as a worldwide disease, which it most certainly was, and the fact that it came through transport. This was during a time of war. That's why it came to the United States, was through military shipments back and forth, you know, from here to Africa or here to Europe. So I think those are definitely the parallels, as is certainly the way, as I said, the public reacted to it. With the fear and the fact that they did not, it wasn't that there was a work, like a mandate, do not go to work, but a lot of people just refused to go. Because it was a 3% death rate in the industrial sector. And so, yeah, the people just weren't going to show up. I believe the percentage was 40 to 60% not showing up. And it was either because they're just refusing to go out of fear, or also because they're having to deal with sick loved ones as well. So all of that, and then of course that was the first time you had the mandatory masks that, due to various municipalities, it depended on where you lived as to whether that was mandatory. So you had all of those lessons, I mean, all of those parallels. And then I would say the lessons was just dealing with medical and scientific preparedness as best as you could do it. Now, of course, with influenza at the time, they did not have the research tools to be able to detect this type of virus. They didn't have those type of microscopes were not developed until the 1930s. That's when the flu vaccine came out. But they were trying to find one at that time. And so I think it was the ability of the scientific preparedness as best as you could do it, the medical preparedness, and certainly a conformity among the public to abide by the dictates of your public health officials as much as they know at the time.
It's really fascinating because with these parallels, there's, you know, the public health steps that were taken that are similar, and the human nature, the response to it. It seems like one of the big differences is kind of like you say, just the technology, some of the innovation that we have in terms of identifying or sequencing the virus, for example. At the end of the day, how big a difference, and what does that technology help us to do? Like, is that a game changer, or does it really come back a lot to these basic public health measures to really help defeat an outbreak like this? And either Dr. Wooten or Dr. Weber.
I will say just one thing shortly. I'm going to defer to Dr. Weaver on this one. I would say it is definitely a combination. You have to have the scientific research. You have to have those that work in place, but it's just a public health measure as well. And when you think about that, you think about what we're doing now in terms of everyone's got to be in the game.
Yeah.
But Dr. Weaver can be a much
certainly the most important things that we're doing right now are no different than during the 1918 flu outbreak. That is trying to keep people from congregating into close groups without spacing themselves out, trying to keep people from going to work when they're sick. But the advantages that we do have today is that we do have very good testing. We've had problems with capacity, especially here in the US, but we do have a very sensitive test, very simple to administer, that if we had ideal capacity, we would be able to trace every person who tested positive and do more targeted isolation of people rather than this mass stay-at-home strategy, which would probably be better at limiting spread as well as be better for the economy. The other key ingredient that we're missing is enough people to do the contact tracing. If a person does test positive, to find out exactly who they've contacted over the previous few days, isolate and test those people. I think that we're all hoping we'll get to that point in the not too distant future. And that will certainly allow us to relax some of these public health restrictions without the risk of a major resurgence. Regardless, we're going to have to relax some little by little and monitor the situation very carefully. But testing and the public health workforce, I think, are key to what we're missing. The other major difference is that now we have antiviral drugs. Some of these drugs we already know are safe in people, and we can test them very quickly to see if they're effective against this virus. And I think we're already hearing anecdotal evidence. I think we're going to hear more and more very definitive evidence about whether a couple of these drugs work or not. Probably remdesivir results will be coming out in the next few weeks. And if remdesivir is effective at reducing disease and maybe even reducing transmission, that could be a big game changer, because everything we're doing now is because we don't want those high-risk people to die from infection, and we don't want our hospitals to be overwhelmed by those people. If we can start reducing that risk to those kinds of people through an antiviral drug, that will really allow us to have a lot more options for our public health response to this outbreak. And then the other is vaccine development. We did have one human vaccine in place in 1918, but it was really, we didn't even discover or understand why it worked till much later. So we were essentially not in the vaccine era at that time. And now we're in an era where we can develop vaccines very quickly. I think that this was really demonstrated best during the Zika outbreak, when we went literally from knowing nothing about the risk of a virus to having vaccines in human clinical trials in just a few months. And we're also seeing the same thing now with the coronavirus. Unfortunately, to test these vaccines carefully and to approve them safely, it still does take a year or sometimes a little more to go through the clinical trials, assuming that they work very well, that there are no problems with the vaccine. And that's really the major bottleneck to getting a vaccine into place. But hopefully, if we can get a vaccine into place, if there are future waves of this outbreak, those can be suppressed to a great extent with a vaccine, maybe starting in a year or a year and a half. The other interesting discussion that started taking place very quietly, probably for a few months and now more vocally, is whether, because of the severity of this outbreak, we need to take a little bit more risk in our vaccine development. And instead of developing a vaccine, testing it gradually in small numbers of people for safety, we instead accelerate the process. And when we reach the point where we're fairly certain a vaccine is safe, instead of vaccinating thousands or more people and waiting for them to be exposed through transmission, which we hope will not be very common in the future, instead intentionally infecting vaccinated people with the virus, people in low risk groups who don't have underlying medical conditions that would predispose them to severe disease, but to probably just a few hundred people very quickly would determine whether the vaccine can prevent the disease. And that's a discussion that's very controversial. Anyone can be at risk of severe, even fatal infection, occasionally without predispositions, but there's the argument that putting a few people who would be willing to take that risk into such a trial could save tens of thousands of lives, and we should consider that. So I think that's an interesting development. We did that a few years ago with dengue vaccines, but dengue has a much lower frequency of life-threatening infection when it's the first time a person is infected with this virus than this SARS coronavirus 2 does. So this would be much riskier than the dengue, call them human challenge trials.
Yeah. That, Dr. Wooten, that makes me think a lot about the development of the Salk and the Sabin vaccines with polio, with a lot of that kind of trial and error and almost derailing the program before the new one came on. Do you want to talk a little bit about that? I mean, I thought that was a really, really interesting game changer when it, with one of these past outbreaks that happened.
Right. Well, definitely, it as Dr. Weaver was saying, it took years to come up with a polio vaccine, and Jonas Salk was the first one who began to work on that, in which the National Foundation for Infantile Paralysis, as March of Dimes as we know it, they were our major funder. You had the NIH, you had funding, but it was the National Foundation that was putting most of the money into finding this vaccine. So when the National Foundation found out that this young man at the University of Pittsburgh was working on this virus, and on this vaccine, he seemed to have something, then they became very interested in it. And so what the Salk vaccine does, he was first got this big grant in 1952, and then began to really move up on his testing and perfecting of this vaccine. But what the Salk vaccine does, and why it is different from the Sabin, is that the Salk vaccine was created as in response to thwarting paralytic polio. As I had said before, most polio cases are not that. It is the ones that we know of, that we are, that you remember because you have those physical manifestations. But what the Salk vaccine did is, because the virus usually would be ingested in the mouth, lodge into the intestinal tract, flourish there, and then is shed through the stools. But for a paralytic case, the virus would find itself breaking through that intestinal wall or into the bloodstream, and they would attack the central nervous system, and the interior horn cells of the spinal cord. So what Salk's vaccine does, and for those who remember taking the Salk vaccine, it was a shot. It was injected. And so it went directly into your bloodstream, and then it would create, if you came out with if the virus was entered your bloodstream, then you'd have these antibodies that would attack it before it hit the central nervous system. That was the idea. So that vaccine, in order for that to know if it was effective, it had to be tested, and they tested it on our first, second, and third graders, throughout the United States. So when you think of that, you think of parents now and how they were then, where they put their children out there and volunteered your dearly loved children to be part of this Operation Polio, as it was called. And so that went throughout the nation, 650,000 children in all. And that occurred in 1954, spring of 1954. And then it was announced that it was indeed safe and that vaccine was safe and effective in 1955, one year later. Now, what that did though is it had a protection rate of about 70%, which was huge if you had absolutely nothing before, but it had 70% to protect against paralytic polio. But then you have Albert Sabin coming along, and he had been working on his vaccine the whole time, and he was definitely wanting to have a vaccine that would attack, go into the intestines, flourish there, and create this, what we would call a gut immunity that would then create a herd immunization. And so, because he came out with this in 1959, too many people had already been vaccinated in the United States. He didn't have a good population sample. So he went to Russia, and he was born in Russia, and Russia was a primary breeding ground for the Sabin, for polio at that time. And so he vaccinated 77 million individuals.
Wow.
And that, which was about 30% of the population. It was proven, yes, that they were immunized, but he brings it over here to the United States. And as I understand the story goes, well, no, before it's going to be, put into effect here in the United States, there's more tests need to be run. Like, what is the level of immunization that this vaccine really creates? So for all of we here in Houston, that's a nice Houston story, was that the National Foundation, again, was delivering these grants to research, do some more testing to be able to determine the immunity level of this vaccine. So you had 3 medical schools who got grants to pursue this. One was Yale, one was Case Western in Cleveland, and one was Houston's Baylor College of Medicine. In fact, they got the largest grant. And the director of that endeavor was Joseph Milnick from Baylor. And what they were trying to do is to see if exposed family members and playmates would acquire this immunity through the contact of a child that they'd given the vaccine to. And then, so they could measure the antibody levels in these individuals. And that is how they found out that, yes, the Sabin vaccine is safe and effective. It has about 99% effective rate of all types of polio. So I think a lot of us, including myself, that was the vaccine that I remember. And it wasn't just your children that were given that. Everyone was given that to create this herd immunity throughout the United States, and then it was implemented worldwide. But those Sabin Sundays is what they had it when everyone lined up at schools or churches or community centers and took that sugar cube that you might recall.
A lot more palatable than the shots for some people, I imagine.
Oh, absolutely. It was more palatable, and it was just so much less expensive because it was easier to transport, and you didn't have to deal with the syringes and equipment like that, which was really one of the reasons why Russia, they were suffering from polio at the time, but they didn't have the syringes to be able to implement the Salk vaccine effectively. So that's why they were more than willing for Sabin to test that vaccine on their population.
Yeah, and I believe, like, as we're trying to approach eradication of polio, which would, I guess, be the second disease eradicated, that the countries are trying to think of, it's Afghanistan, a couple of the countries that still have polio and are trying to eliminate it from the population are still using that type of vaccine for that reason, because it's much easier to distribute. Yeah,
right.
That's fascinating.
Yes.
I could talk about all of this all day. I want to make sure that Katie, if anyone has any questions, that we make sure that we have time for Dr. Weaver and Dr. Wooten to answer them. So if anyone does have any questions, be sure to put them up there. While we're waiting to see if there's any questions, Dr. Weaver, right before the call, you were saying you've been pretty busy. Are there any specific things that the research community is really kind of working on right now, or any of like the sort of really important pieces to dealing with this outbreak right now?
Well, I think that development of animal models is one of the key bottlenecks that we're certainly working very hard at UTMB on. New diagnostic tests to detect antibodies in people is a big topic. There are a lot of commercial assays starting to come out right now. And in fact, in the news, you may have seen that some research groups are evaluating these assays and finding that many of them do not perform very well at all. So I think improvement in the ability to detect antibodies in people, and this is very important for a couple of reasons. First of all, if we know that you have been infected and you have immunity, and we assume that that's going to protect you, that means you can go back to work or even do some of the higher risk jobs if you work in healthcare or some of the service industries without putting yourself at risk. And it also tells us how many people in the population have already been exposed, and that's pretty good information to allow us to predict better what the future of this outbreak may look like. So for example, in New York, it was just reported a few days ago, there were several thousand people selected, not exactly at random, but fairly close to that, by just standing outside of supermarkets and offering people the ability to be tested to see if they have antibodies. And it turns out that in New York City, according to this report, it's not been peer reviewed yet, but it's probably fairly accurate. About 20% of people in the city have already been infected. So first of all, that means that there were a lot of people who were infected who didn't even seek healthcare. They probably were not very ill. A few of them may have not had any symptoms. Second of all, it tells us that New York is starting to get to the point where that level of immunity will suppress the efficiency of spread a little bit. Probably not till we get closer to 50% will it really have a major impact on spread. But that's the kind of information we need to have for everywhere in the country to know where we stand with this outbreak, to know whether we're missing a lot of transmission from people without symptoms. And the more and more that we learn, the more we realize that that is true. In fact, that's why the recommendations for people to wear masks are coming out now, because we know a lot of people are spreading the virus who have no symptoms and wouldn't even think of putting on a mask if we didn't tell them to do that. So these antibody tests, I think, are really critical progress that's being made right now. And then vaccine development, which you don't hear a whole lot about in the news because they're very small trials with a few of these now. Usually about 50 people receive the newest vaccine just to determine whether it has any serious adverse events. And if it doesn't, then we progress to what we call phase 2, where usually a few hundred people are evaluated. And with each one of these clinical trials, at the very end, we learn whether the vaccine generates immunity. That doesn't necessarily mean that it will protect people, but it's some indication. So I think that the vaccine trials are making fast progress. We're not hearing about them yet because we're at the very beginning stages where we don't generate as many data, but the data are going to be accelerating on the vaccine front very quickly in the next few months. And we're going to start learning whether these vaccines are really promising or not. So I think those are two of the major advances in research going on right now.
Has the timeline for the vaccine development changed at all? There's a question that came through about when to expect the vaccines.
Yeah, I think there was a question about what the fastest one in the past has been. If you look at historically at the time between when a vaccine was first conceived by a scientist and then the time it took before it was licensed and available for everyone, I think the shortest in the past was 4 years, and that was for the vaccine against mumps virus. which you don't hear much about anymore because it's included in the childhood MMR vaccine for mumps, measles, and rubella, and most of the population is vaccinated, so we don't see much mumps anymore. But 4 years was very fast during that time period. And so it certainly isn't unreasonable to think that it can be faster now, because the scientific part of it and the animal testing can happen much faster now than it could a few decades ago. But I think the human clinical trials still have to be done carefully. And the reason is that we have a history with a few vaccines. Probably the most famous one is a virus called Respiratory syncytial virus, which is a very serious, sometimes deadly respiratory disease of young children. Most of us are immune. We all get infected as children, but some children get very serious illness, have to be hospitalized, and occasionally can be fatal. And the first vaccine that was developed and tested against RSV at the beginning looked very good. It didn't cause any problems when it was given to naive children who hadn't been exposed to the virus. There were no serious adverse effects. Those children did develop measurable immunity. But what happened was, when it was started to be used in more children, and those children then were exposed to natural infection, that infection was actually worse than if they had not been immunized at all. And that vaccine caused the wrong kind of immunity that predisposed people to even more severe disease. So we have to do these trials very safely to avoid that kind of an outcome. And that's what I think is difficult to understand. If we have a vaccine and it works in an animal and it looks safe in people, why don't we just give it to everybody? But that could lead to a disaster, as we've seen with that respiratory syncytial vaccine.
Now, the vaccinations that they're working on, the question as to which strains it would likely cover. Are the strains similar enough that the vaccines that are being developed would work on more than one, or do they have to develop different ones for different strains?
Well, most of the vaccines being developed are targeted to the one strain, SARS coronavirus 2, and they're probably going to have some impact on the original SARS coronavirus if it were ever to reemerge, and maybe other very closely related coronaviruses that we know are circulating in bats all the time. Probably once you get to the more distant relatives of the new SARS coronavirus, like MERS or the common cold type viruses, probably there's not going to be very good protection against those. Based on what was done with MERS and SARS vaccines in the past.
Now, with the mutations that you're seeing, are you seeing a lot? Is this virus mutating a lot, or is it?
It's mutating just like we would expect any RNA virus. Viruses that have RNA or ribonucleic acid as their genetic material tend to mutate very rapidly. It happens with all of them that infect us, like influenza, rhinoviruses that cause common colds. This virus doesn't appear to be really any different. The only major difference, if you compare it to influenza, it doesn't have multiple genetic segments, which are sort of like our chromosomes. And when two different strains infect the same person or same cell, they can reshuffle their genetic material, just like the reshuffling that happens when humans reproduce, and generate a completely new combination of genetic segments. And that's why we have pandemics of influenza. Avian strains from usually water birds like ducks and others combine with human strains, or sometimes swine strains, and generate a complete new combination of genes and proteins that people have never seen before, haven't seen in many decades. And then we see outbreaks that spread around the world because there's no immunity in the population. Coronaviruses have only one genetic segment, so they don't have that kind of extra ability to change very rapidly like flu strains. And that's a little bit of good news in that flu is really one of few viruses that are able to do that. And it causes a big problem in us predicting what to put in the vaccine each year to try to prevent disease 6 months later. That's one of the reasons that sometimes our flu vaccine is very effective because it's targeted against the strain that happens to be widespread the following winter, but sometimes we guess wrong and it doesn't work so well.
Mhm.
This coronavirus will be much simpler in that there's really only one target we need to worry about. The original SARS virus is not circulating outside of its bat ancestral virus, and we can focus on this one coronavirus now.
That does seem like a very positive thing. And then there's a question that's come through about the antivirals, antivirals like Tamiflu, and whether or not they seem to have any impact on the COVID-19.
Yeah, well, that information is just starting to come out. There have been a few peer-reviewed publications the past week or two on hydroxychloroquine that we've heard a lot about. Anecdotal reports from physicians in Italy and other places suggested that this was really making the disease better in severely ill people. But the only way we really ever know whether a drug works or not is to do a controlled trial where usually when it's a brand new virus like this coronavirus and nothing is known to be effective, we start by comparing a drug like hydroxychloroquine to a placebo, no drug at all. And if the drug prevents severe disease compared to the placebo, we know it has some effect. And then the next stage, we test that drug that has some effect against newer drugs to see if they're better or worse. So unfortunately, the hydroxychloroquine results indicate that in some very severely ill patients, that drug can lead to a worse outcome. There's no evidence that it leads to a better outcome. So that drug really should not be used at this point. It's licensed for other uses, so physicians can prescribe it, but hopefully they'll stop doing that now. I think the next one to come along is remdesivir. I think there's reason to be more optimistic about remdesivir. We've heard some anecdotal stories from physicians in Chicago who were, I guess, taped on a video talking about the results with their patients. They seem to be very encouraged. And I think within the next few weeks, we'll see the first data on the placebo randomized clinical trials that will really tell us for sure whether remdesivir is effective or not. And then a few other drugs coming not long behind that one. So I think that if any of these drugs is efficacious, that's going to be a big game changer in how we prevent people from dying, but also we can think a little bit differently about our public health responses if we don't have that risk of many fatalities and our emergency services and ICUs being overwhelmed by severe patients.
Well, Dr. Weaver, thank you so much for all that you're doing over at UTMB and all the research that you and your colleagues are doing. I think I speak for everyone when we say how incredibly grateful we are. And Dr. Wooten, thank you too so much for joining us. It's hard to believe it's already going on 7 o'clock, so I'll turn it back over to Katie.
Thank you all very much for this really informative session. I feel a little bit relieved and from all the information that we've been getting funneled in for the last 6 weeks, knowing that our healthcare professionals are still hard at work and we've taken what we've learned from our history and are applying it to today, and that the future is looking up for us and that a virus hasn't beat us yet. But before we conclude, I would like to bring on another special guest with us. We have our President and CEO, John Archidiakonou. John, are you online?
There we go. Am I unmuted?
Yes.
Thank you, Katie. First of all, really quick, Dr. Wooten, Dr. Weaver, thank you so much for your time. We really appreciate this. This is wonderful to hear from you about the past, the present, the future, and the hope that we have. So we're excited about that. So thank you very much. And thank you to our members for attending tonight. I think you understand this is what the Health Museum is all about. As Katie said earlier, we're not open currently, and we won't be opening quite too soon, even though the governor just came out with some announcements. We are going to be very, very specific and very measured as we decide when we're going to be opening. But when we do, we want you to come by and see our Outbreak exhibit that we've been talking about and our artificial intelligence exhibit. So with that, thank you all for being here. And Katie, we're done, we're done, or you can say something else.
Yeah, I'll go ahead and stop the recording. Thank you guys all for joining us tonight. I'll still be on the call if you guys have any last minute questions, but this will end the official recording.